Hello everyone, welcome to Raaonline. I am Dr. Venkateswaran, consultant psychiatrist. So today we are going to discuss about dissociative disorders. So we'll start with a brief introduction. What does ICD-11 says about dissociative disorder? Okay, dissociative disorders are characterized by involuntary, means here the children or adolescents are not doing voluntarily. Involuntary disruption or discontinuity. There is a discontinuity in what? In normal integration. Okay, of one or more of the following. Usually what happens, all these entities, okay, are normally integrated for the smooth functioning of the individual. So in dissociative disorder, what is happening? There is an involuntary disruption. Okay, here they are not voluntarily doing, they are not willfully creating any symptoms. So there is involuntary disruption of normal integration of one of these features, like that is identity, sensation like touch, vision, etc., perception like how we perceive environment, affect our mood, our thoughts, memories, control over bodily movements. Okay, all these things are normally integrated for the day-to-day functioning, but here there is an involuntary disruption in all these entities leading to dissociative disorder. Why this involuntary disruption happens? Due to stress. Okay, when there is extreme stress, when there is an emotional state, this involuntary disruption of these entities leading to dissociative disorder. Okay, it may be complete or more commonly it is partial. Okay, and it can vary from day to day. It can occur in episodes. It vary from hour to hour. Okay, this is the definition of dissociative disorders. Okay, as per ICD-11, what are all the dissociative disorders? Most commonly, what we see in children is dissociative neurological disorders, commonly non-epileptiform seizures and other neurological disorder. Dissociative amnesia, that is memory loss, trance and possession disorder. Okay, sometimes it is trance or sometimes it is possession. Dissociative identity disorder and partial dissociative identity disorder. Okay, these are all dissociative identity. In olden terms, it is called multiple personality disorder. Depersonalization and derealization disorder. Okay, so these are the types of dissociative disorders. Okay, most common is dissociative neurological disorder. So first we will see dissociative neurological symptom disorder. Okay, here involuntary disruption, as we saw in definition, there is an involuntary disruption or discontinuity in the normal integration. Normally it is integrated, all these phenomena are integrated, normal integration of motor, sensory, cognitive functions lasting at least for several hours. Okay, these are all the neurological functions. Okay, motor, what we do, sensory, what we take in, okay, and cognitive, what we think. Okay, when there is an involuntary disruption of these functions, it results in dissociative neurological disorder. Okay, and here it is very important that the symptoms are not due to another known medical, neurological or psychiatric condition or substance use or sleep disorders or other dissociative disorder. For example, if there is neurological symptoms due to, if the dissociative identity disorder is identified, then the memory loss is not diagnosed as dissociative neurological disorder, it is part of dissociative identity disorder. Okay, specify if it is due to visual disturbance. For example, complete blindness, tunnel vision, diplopia, double vision, visual distortions or hallucinations, which is not part of schizophrenia or any other organic condition. Then dissociative visual disturbances, dissociative auditory disturbances, complete loss of hearing or auditory hallucinations, which is part of major psychiatric disorders or major neurological disorder, vertigo or dizziness, dissociative vertigo or dizziness, sensation of spinning while stationary or dizziness. Okay, these are all specifiers. Other sensory disturbance like non-specific numbness, tightness, tingling, burning pain and other symptoms related to touch, smell, taste, balance, joint position, that is proprioception, kinesthesia or thermoception, like variation in perception of temperature. Okay, so all these things can occur as dissociative disorder after extreme emotional stress. Okay, and more importantly, we commonly see dissociative non-epileptiform seizures. Okay, presentation of seizures, but it is not a true convulsion. So differentiating point. Why I have given emphasis to PNES, it is very common in children and adolescents. Okay, the dissociative convulsions, the pointers include pre-ictal, there may be more anxiety and seizure may be sometimes induced. Okay, this is called suggestibility. Okay, when there is suggestibility, then it is likely to be PNES, psychogenic non-epileptiform seizures. During ictal phase, inconsistent variable sequence of events. Okay, in true seizures, if you see, there is a clear tonic, then followed by clonic movements and resolution. Here there will be varied movements, okay, occur especially when others are present, and it has a gradual onset. Okay, ictal true seizures, it has a sudden abrupt onset, it has a more gradual onset, and usually it is very prolonged. Seizures are usually, unless it is status epilepticus, it is usually less than few minutes. Here usually all the episodes are more than 2 minutes. And asymmetrical limb movement or pelvic thrusting movement, sideways shaking of head like this. And here the ictal features like incontinence, injury due to serious injuries due to fall, frothing, tongue bite, all these things are rare. Okay, like in true seizures, all these things are common. Here all these things are rare. And when you examine, there is a normal autonomic reactivity and pupillary responses. There won't be any BP pulse fluctuations after pseudo seizure. Vocalization may be present throughout the seizure. They may vocalize, I am having pain, I am hungry, all those things can occur during seizures. They will avoid noxious stimuli. Usually it is generally not recommended to present any noxious stimuli in the process of testing for seizures, like pungent smelling, cotton, etc. Avoid all those things, but in generally in dissociative state they will avoid noxious stimuli. And the eyes will be usually tightly closed, and when you try to open, they will avoid eye opening, okay, and they will avoid gaze. And gold standard for diagnosis of dissociative convulsions is when the patient is having dissociation and when they do ictal EEG, okay. Interictal EEG is not the gold standard, okay. Even interictal EEG is abnormal, intellectual EEG is normal. The dissociative disorder is based on the dissociative convulsions are based on the semiology rather than EEG finding, okay. But if ictal EEG is normal when the patient is actively seizing and when they are parallelly recording EEG, if it is normal, then it is likely to be dissociative disorder. Interictal EEG, again, it doesn't have any diagnostic significance in dissociative disorder, because even if the EEG is interictal EEG is abnormal, if the semiology is clear, we can still go on to diagnose dissociative disorder. Okay, so normal ictal EEG. Post-ictal, there won't be any post-ictal delirium or confusion, and subsequent recall of events is possible in dissociative disorder. In seizures, it is not possible. No rise. If you immediately measure prolactin, there won't be rise, but again the prolactin may be normal in partial seizures. Only in GDCS prolactin may be increased. So these are the features of dissociative non-epileptiform seizures, okay, in comparison with true seizures. Speech disturbance. The specifier is applied if dissociative neurological symptom is characterized by difficulty in speaking, dysphonia, okay. They will have difficulty to speak or a complete lack of speech, that is aphonia, and difficult or unclear articulation, dysarthria, okay. Any of these symptoms can, if it is not neurologically explained, then it can be dissociative. And weakness, and this is after pseudo seizure. This is another common phenomena seen in children and adolescents. It is applied when dissociative neurological symptom disorder is characterized by difficulty or inability to move the part of body, usually common in lower limb. They will not be able to walk. But if you do the neurological examination, it will be normal. Power, tone, reflex, all those things will be normal, but they will not be able to walk. They will not be able to lift the limb, or hand function will be lost. And it is not explained by any known neurological disorder, that is dissociative paralysis or weakness. Gait disturbance, and it won't be fitting into any known organic gait pathology, but they will have very difficulty in walking, or usually the ataxia, okay. They will have unexplained difficulty in walking, or even inability to stand if unaided, okay. This is also another common. Gait disturbance are also very common in children and adolescents. Movement disturbance, again, it is very difficult to diagnose dissociative movement disorder, because the movement disorder itself will be very dramatic and very atypical. Sometimes all this chorea, sometimes it is not easy to diagnose in the first instance. So we should be very careful when we are suspecting dissociative movement disorder, because even the diagnosis of organic movement disorder, it's a very challenging entity. So diagnosing dissociative movement disorder, we have to be doubly careful, and it is preferable to take a second opinion from another specialist in the field to diagnose dissociative movement disorder, okay. Movement disorders include chorea, and here it is not explained by medical cause. involuntary, irregular, non-repetitive, brief, jerky, flowing movements or dancing like movements is called chorea. When it is not due to any medical disorder, then we can consider dissociative chorea. Myoclonus, here sudden involuntary twitching or jerking of a group of muscles. Tremors, involuntary oscillation of a body parts, more commonly hands or head. Okay, and it can be occur during attempted relaxation or during voluntary held posture, like when we ask the patient to do like this, or during a voluntary movement, intentional tremor. Dystonia, it is disturbance include involuntary muscle contraction that cause slow repetitive movements or abnormal postures. Okay, that is pulling of neck to one direction or upward looking of eye for a little longer time. Okay, so this is dystonia. Again, as I was telling before, the dissociative movement disorder, we should be very cautious in making diagnosis. Facial spasm, involuntary twitch that occurs in the face mimicking tweaks. Parkinson's, it includes all Parkinson's signs like rigidity, tremors, bradykinesia, postural disturbances. This is a little common, but it will present only as bradykinesia. In clinical setting, the children or adolescents may present as bradykinesia, overall slowness of movement. So, sometimes the gait disturbance will also be seen, but when you examine, the tremors will not be seen, rigidity will not be seen. Okay, and sometimes it will be highly fluctuating. Sometimes they will be slow, sometimes they will be normal. In Parkinson's, true Parkinson's disease, most of the time they will be slow. In childhood onset Parkinson's is very rare. So, if you see Parkinson's disease, then there is a possibility that it can be dissociative disorder, and it won't present with all the symptoms. Okay, most commonly present with bradykinesia and gait disturbance, and there won't be much tremors or muscle rigidity on examination, and there won't be any medical causes or genetic causes explaining childhood onset Parkinson's. Okay, so these are all dissociative movement disorders. Cognitive symptoms. Okay, dissociative neurological disorder that is characterized by impaired cognitive performance, that is memory, language or other cognitive domains include personality, that is internally inconsistent. The cognitive deficit not is consistent. Okay, sometimes the child has memory, sometimes the child don't have memory, and not consistent with any neurological disorder or neurodevelopmental disorder like intellectual disability or early onset neurocognitive disorder or neurodegenerative disorder or another mental disorder or other dissociative disorder. Okay, this is dissociative cognitive disorder. The child has memory problems that is not explained medically or neurologically, and it is not part of neurodevelopmental disorders like intellectual disability or neurodegenerative disorder where it presents with cognitive decline. Okay, what is the course features of this dissociative neurological disorders? Okay, onset of neurological symptoms typically occurs between puberty and early adulthood, like 12 to 20 years, and is usually very acute. And the disorder may follow either transient or persistent course, depends on the etiology or nature of the stress. And onset is usually associated with traumatic or adverse life event like physical injury or child abuse or child neglect. In addition, usually the prior disease of nervous system will be there. Okay, especially the pseudo seizure, PNES is common when there is a history of true seizure, and this adds confusion to the diagnosis. Most often they end up treated like a seizure with escalating dose of anti-epileptics, and in the end when the symptom doesn't settle, the dissociative disorder is suspected. So, we have to be very cautious when there is a atypical symptom presentation in child who has already had seizure or even with previous neurological illness. When they develop, the first thought of the consultant and the parents is the previous neurological disorder has relapsed. So, invariably they get evaluated for physical conditions, and sometimes it results in significant delay in the diagnosis of the underlying psychological conditions. So, positive prognosis in dissociative neurological disorder include younger age, acute onset. If the symptoms are very chronic, it has a little poor prognosis, like in any case. Short duration of symptoms and monosymptomatic presentation. If the presentation is very complex, then it has a poor prognosis. Early diagnosis and short interval between symptom onset and initiation of treatment. If they are suspected early and initiated treatment early, then it has a poor prognosis. And clear onset associated with identified stressor. For example, in other way, we have identified what is causing dissociation, and if we couldn't identify stress, then it has a poor prognosis. And good premorbid functioning and intelligence. premorbidly well adjusted, a severe stress causing dissociative disorder, then the outcome is good. The premorbid functioning itself is less and having lots of personality or temperamental issues premorbidly, and there is no clear identifiable stressor, because these are the commonly seen entities. There won't be identified stressor, the child has poor coping abilities and there is poor functioning premorbidly. When they develop dissociative disorder, again it has a difficult course. And the family's acceptance about psychological nature of the condition. If the family is willfully accepting, or it is easily the consultant is convincing the family, then it has a good prognosis. Sometimes the family will be very hostile and not receptive for the diagnosis of dissociative disorder. Negative prognosis, non-transient symptoms, polysymptomatic presentation, more than one symptoms, comorbid medical condition and mental health condition. When it is associated with, for example, dissociative seizures is associated with true seizure, then it adds to the diagnostic confusion, it results in the poor prognosis. As I was telling, maladaptive personality traits, and sexual abuse has a poor prognosis, previous history of sexual abuse, poor physical functioning and overall functioning prior to the diagnosis of dissociative disorder. So these are the factors associated with poor prognosis. So developmental aspects, gait disturbance and non-epileptiform disease or seizures are the most common. As I was telling before, dissociative gait disturbance and PNES are the most common dissociative neurological symptom disorder in children and adolescents. Most common psychosocial stressors associated with the dissociative neurological symptom include bullying or victimization, school-related stressor, academic stressor, family conflict or parental separation, or death of relative of a friend. So these are the common stressors associated with dissociative disorders. Children with dissociative neurological symptom disorder often grow up in families that is excessively preoccupied with illness. So any symptom, they will give excess attention. So when the child is having stress and when the child cannot express the stress, most often they use medical model and it is expressed as medical symptom. And the family gives excess attention to the symptom and it results in significant secondary gain leading to the persistence of dissociative disorder. So this is a family functioning even before the onset of symptom. The family generally gives excess attention to any illness. Adolescent with dissociative disorder usually have co-occurring mood disorder or anxiety disorder and other medical symptoms, because usually the onset of these mood disorders and anxiety disorders is common in adolescence. So when an adolescent is presenting with a dissociative disorder, we have to look for underlying physical or psychiatric disorder, most commonly psychiatric disorder, because it has a clear onset in adolescent age. And mood and anxiety disorder can persist even after the remission of neurological disorder, dissociative neurological disorder. Okay, for example, if underlying anxiety presenting with the dissociation, even after dissociation is cured, this anxiety disorder persists. Okay, so we saw about dissociative neurological disorder. Then next we will see about other dissociative disorders like dissociative amnesia, trance and possession, dissociative identity disorder, depersonalization-Derealization. Then course and specifier for these disorders are common. Okay, we will see that in the end. Okay, so here dissociative amnesia, inability to recall autobiographical memory about their own memories, typically recent traumatic or stressful event. Okay, memory to the traumatic event will be lost, and it is inconsistent with the ordinary forgetting because it causes significant dysfunction. It is not just forgetting. Because of the amnesia, the children or adolescent will have significant difficulty in day-to-day functioning, and it is either associated with dissociative fugue or without dissociative fugue. What is dissociative fugue? A loss of sense of personal identity and sudden travel away from home, work or significant others for an extended period of time, days to week. Okay, sometimes dissociative amnesia is associated with dissociative fugue, or sometimes it is not associated with dissociative fugue. Okay, so this is dissociative amnesia. Trance and possession disorder, characterized by recurrent or single prolonged involuntary marked alteration in individual's state of consciousness, involving either just a trance state without possession or a possession trance state. Okay, so it is the marked alteration and prolonged, not just some memory disturbance or conscious disturbance. It is a prolonged involuntary. The child or adolescent is not doing voluntary. Prolonged involuntarily marked alteration in the individual's state of consciousness. Okay, involving either trance. We will see about what is trance. Involving either state of trance without possession or possession state. Possession trance disorder. Here, the individual's normal sense of personal identity. Okay, they will have, everybody have their personal identity. I am so and so. Okay, that is replaced by external possessing identity. Okay, usually influenced by a spirit, a power, or deity, or spiritual identity. Okay, they get possessed by the other identity, and their behavior is suggestive of that possessed identity rather than their normal identity, normal personal identity. So this is possession, trance possession state. Okay, trance state without possession, in which there is marked alteration in the individual state of consciousness or loss of individual's normal sense of personal identity without any possession. Here we can see narrowing of awareness of immediate surrounding, okay, and selectively focusing on a specific environment, focusing on a bottle. Here my normal identity is lost, there is a transient alteration in the state of consciousness, and awareness about what is happening out around me is lost, and I am focusing excessively on any particular or irrelevant environmental stimuli, and it also results in restriction of movements. They just keep seeing that particular object, or they will just somewhere. Restriction of posture and speech, they will have some repetitive. Okay, for example, if a girl was abused by uncle, they develop dissociative trance disorder. They will be unaware of the other uncle, like that. Okay, they will have the trance state. Okay, and that is experienced as being outside the individual control. Here the individual is not doing voluntarily. Okay, it is outside the individual's control, and suddenly the child's consciousness, state of consciousness is disrupted, and there is a repetitive speech, restriction of motor activity, and it is unaware of the surroundings. The actions performed during trance state are generally not complex, but during possession trance state, the activity performed is more complex. Okay, they will have a coherent conversation, characteristic gestures, facial expression, specific verbalization. Okay, the presumed possessing agents in possession trance disorder are usually spiritual in nature. Okay, and during this complex movement, they will take the usual character of the possessed person. Okay, that is possessed agent. Okay, so in trance state, the action performance are simple in nature, but in possession, it is complex. This is about trance and possession disorder. Next is dissociative identity disorder. Previously, it is called as multiple personality disorder. Okay, here disruption of identity characterized by two or more distinct personality state. Okay, at least two or more personality state involving marked discontinuation in the sense of self and agency. Okay, it's a discontinuation in sense of self and agency means, okay, I am the agent of my actions. Here that is lost. Okay, so I am not the agent here. Okay, each personality states include its own pattern of experiencing, perceiving, conceiving, relating to self, the body and the environment. So each personality will have their different nature of experience and perceptions. And two distinct personality states recurrently take executive control of the individual's consciousness, functioning and interacting with others or with the environment. Okay, and to at least two distinct personality recurrently take executive control of the individual's consciousness and the way they interact with the environment. The changes in the personality state are accompanied by related alteration in the sensation, perception, affect, cognition, memory, motor control and behavior. Okay, each personality will have distinctly these areas. And alteration between the distinct personality is not always associated with amnesia. It can be associated with amnesia. Substantial episodes of amnesia are typically present, but it is not always associated with amnesia. That is, one personality state, if the person is having two dissociative personality state, one personality state may have awareness and recollection of activities of another personality state, particular episode. So, amnesia need not to be present always. And if the amnesia is present, we need not diagnose as dissociative amnesia or dissociative neurological disorder. It is explained by the dissociative identity disorder. There is something called partial dissociative identity disorder. it is common for one personality trait to be intruded upon, just intruded upon. Okay, that personality will not take over. Okay, it will not have a complete executive control, but it will intrude upon, okay, by the other non-dominant alternative personality state without taking the executive control. If the personality completely take over the executive control, that is complete dissociative identity disorder. In partial dissociative identity disorder, the personality, the non-dominant, there is a dominant personality state and a non-dominant personality state. Here the non-dominant personality state intrude upon the aspect of other dominant personality state. Here the personality state that is intruded upon is commonly experienced intrusion as aversive, and that may not be like it. That is, dominant personality state perceives this intrusion as aversive and may not realize that intrusions relate to features of other personality state. May see as unwanted intrusion, and they may not see this as a different personality state. Okay, this is little confusing. Basically, just remember, sometimes the other personality states just come and go and doesn't take a control over. This is called partial dissociative identity disorder. That's it. In full dissociative identity disorder, the other personality state completely take up the individual's executive control. Okay, this is dissociative identity disorder. Next is depersonalization and derealization. So first we will see depersonalization. Here depersonalization, experiencing self as a strange and unreal, or feeling detached from, as though one were an outside observer of one's own thoughts, feelings, sensation or actions. Here if I am perceiving myself as a second person, okay, so I am perceiving my thoughts as second person, okay, experiencing self as a strange or unreal, I am unreal, okay, I am not existing, or I am detached from myself, okay, that I am observing myself from outside, okay, this is depersonalization, okay. Derealization, this is different, experiencing other people, objects or the world as strange or unreal. People around me are unreal, okay, a dream like distant, foggy, lifeless, colorless, visually distorted feelings of our own surrounding. So derealization is experiencing our surrounding as unreal. Depersonalization is experiencing self as unreal, okay. And here reality testing remains intact, means this is not part of any delusions or hallucinations, okay. In delusions or hallucinations, the reality testings will be impaired, okay. And here it is sometimes associated with catastrophic cognitions, like during the state they may feel like they are going crazy, they don't know what is happening, they will become very panic, okay. And loss of sense of ownership of some memories or physiological hyperactivity to emotional stimuli may be present, okay. They lost the sense of ownership of some memories, or they may not react to particular emotional stimuli during that time, okay. And common associated symptoms is altered sense of time. They may perceive they are either experiencing time as slowed down or time as speeding up. This is also a common associated symptom with either depersonalization or derealization, okay. So associated symptoms of dissociative depersonalization or realization include catastrophic cognition, that is something bad is happening, or sometimes they may lose a sense of ownership of some memories, or sometimes they may not have normal reactivity to the emotional stimuli, and they may perceive the time is either too fast or very slow.